possible to recommend delivery based on the shortening cervical length? No. If delivery is to happen, it should be spontaneous. We don't recommend delivery because the cervix is short. More so before term. Even at term, we don't induce a woman because they have a short cervix. The reason for identifying a short cervix so that we can do the preparatory work for delivering a preterm baby. So that if the woman we know is likely to deliver, we give antenatal steroids, we warn her not to travel far away from the hospital, and we also begin to counsel her. We warn her to also not to travel far away from the hospital, so that if problems do occur, people will be ready to attend to her. That's the reason for identifying a short cervix, not to deliver. Sometimes you may want to give progesterone for women who are below 34 weeks. There could be some benefits in giving them progesterone if preterm labor, the risk of preterm labor is high, but not to deliver them. Right, so it's now 28 or 29 past. I have 2 watches with me, so I don't know which one is correct. We will start the next segment of our meeting. So, like I said from the beginning, we have a wonderful team of presenters who are all local, which is a very a great achievement to have doctors who can address this complicated area of obstetrics. So the next speaker is Dr. Dube. Dr. Dube is an obstetrician and gynecologist at Mpilo, and is also a fellow, a passionate fellow of fetal medicine in Bulawayo. And his passion is pre-eclampsia. He feels the pain that most women do feel. Those who come with severe fetal growth restriction, those women who go through our labor wards with damaged kidneys, with CVAs. So Dr. Dube actually feels the pre-eclampsia. So there's no question that Dr. Dube is very passionate about pre-eclampsia, and he thinks we can do better than what we are doing to try and address the scourge of pre-eclampsia. Just like William Ballantyne said to his colleagues of Edinburgh in the 19th century, where it was 1906, I think, where he told them that it was better to identify the evils of pregnancy early before they become pregnancy dangerous. So this is the topic of Dr. Dube today. He's going to be talking to us about pre-eclampsia screening. Pre-eclampsia is a pregnancy dangerous. It's causing pain, untold suffering, and a lot of damage to our women here in this country. For those who work in the high-risk hospitals, I'm speaking things that are close to you, that you witness every day. Probably we have doctors in the hospital right now. They are witnessing this scourge of pre-eclampsia. So please, Dr. Dube, take over and let's proceed.
Thank you very much, Dr. Berenga, for the opportunity that you've given to me to be able to make this presentation. And as we have rightfully said, so this condition actually has become a big thorn in my flesh. Day in, day out, I actually come in contact with some of these women who have been damaged by preeclampsia, who have delivered early due to preeclampsia, and who are predisposed to several long-term complications arising from this disease. So it also gives me great pleasure that I'm making this presentation in the month of May. And as some of you may know, this is our Preeclampsia Awareness Month. And tomorrow, the 22nd of May, it is indeed, well, World Preeclampsia Day. I'm very happy because this disease is now being given some form of recognition. There is an awakening in the world to say preeclampsia is a disease that we need probably to focus more on than we've been doing. And I also want to believe that a lot of effort has actually gone in reducing sepsis, postpartum hemorrhage, but not so much of effort has actually been put in us trying to predict preeclampsia and in trying to prevent it, especially in our setting. And for me, really, I really want us to talk about preeclampsia until it is given, I think, the same recognition as HIV. You know how HIV became so much of a scourge that we are actually routinely screening for it, even in pregnancy up to today. Although we know that we are being told that our PMTC has worked so well that it is now even rare for a woman, for a baby to get HIV through normal labor and delivery in our setting currently. That is exactly how I want us maybe to talk about preeclampsia until it has such recognition in our country. So what is it that we're talking about? I think FIGO in this article, they were quite clear and they were quite unambiguous in really characterizing the disease in this slide. They said that it's a condition that affects about 2 to 5% of pregnant women. In Africa, in some of the African countries, it is as high as 8 to 12%. And we know that it is actually the leading cause of maternal and perinatal morbidity and mortality, where it is estimated globally that 66,000 women die each year from preeclampsia, and globally 500,000 babies die each year from preeclampsia. And that the commonest deaths actually are occurring in our setting, especially in our low-resourced countries such as ours. We know that the effects of preeclampsia do not just end at delivery, but they may continue to cause significant morbidity in the woman in terms of developing long-term complications, such as some cardiovascular diseases, diabetes, obesity, and even the infants that are born to these women are usually born prematurely, and they also are at risk of several other long-term complications that in the interest of time, I will not be able to go through all of those. But what is surprising is that we know which patients are actually at risk of developing preeclampsia from risk factors alone, such as chronic hypertension, renal disease, autoimmune diseases. And we know that advanced maternal age, nulliparity, obesity, ethnicity, just being Black, like Dr. Verenga mentioned before the break, puts our women at higher risk of developing preeclampsia than at any other place in the world. But what's so surprising is that we do not seem to be doing anything about predicting it. We seem to be comfortable managing the condition, chasing after the complications, running day and night to deliver premature babies, congesting our neonatal intensive care units, delivering SGA babies, IUGR babies. So the amount of effort that I think we are putting in managing the condition might as well be put in predicting the condition. So there are a series of 4 questions that I want our attendees to be answering as we go along, so that they could be able to, at the end of this presentation, be able to mark themselves and see how much of the condition they know. So the first question there that I put up is, what is the detection rate for preeclampsia using maternal factors only? Is it 40%, 70%, or even 90%? We'll come to the answers during the presentation. So when I speak about this, some people may think Dr. Dube is deriving his assumptions from data elsewhere. So I said, what are the studies that have been done locally to be able to understand the burden of the disease? There's a study that was done in 2017 at Mpilo Central Hospital by Professor Solo Ayongwenya, which actually showed that nearly half of the babies that were born close to stillbirth and early neonatal death. So you can see the burden that this condition is presenting to our neonatal population. And that most of these cases, about 60% of them, of early onset preeclampsia. And that 78.5% of these cases were delivered by cesarean section at our hospital. And all the cases were admitted to to IC after a cesarean section. So you could see how much of a financial problem, how much of a setup burden this disease actually is in our local population. And currently there's a study that I'm involved in where we are looking at characterizing the burden of the disease further and also to assess the implementation barriers of a pragmatic screening protocol. So we have not finished analyzing the data, but this is what has already come out so far. So this data is actually derived from a study that we are doing where we looked at all cesarean sections that were done for an indication of severe preeclampsia or eclampsia in 2021. So from Mpilo Center hospitals, we did 3,528 cesarean sections in total in the year 2021. 392 of these cesarean sections were done for an indication of severe preeclampsia, eclampsia, abruptio, or HELP syndrome. We then went further to say, what were the characteristics of these women that were operated for a complication of pregnancy, which is hypertension or gestational hypertension or hypertensive disorder in pregnancy? So you'd see there from the first bar graph on the left that these are fairly young women. 18.1% of these women were aged 20 years and younger. So you could see that these are 15-year-old, 17-year-olds, 16, 18-year-olds. You would also see there in the middle, the tallest bar there, that these are women who are fairly young, 20 to 35 years of age. 63.5% are already having a cesarean section for preeclampsia or for eclampsia. If you move on to the one where it's indicating parity there, you can actually see that these are women who are of low parity. 49.8% of these women that we operated last year at Mpilo for preeclampsia or eclampsia had no babies, were in their first pregnancy. So we're operating half of our women for preeclampsia at Mpilo in their first pregnancy. But however, I think if you look at the one that is at the bottom, let me put a pointer and see. Dr. Verenga, I think, came back to the slide to say, why do we seem stuck like we are doing? We are again highlighting there that for any preventive measure, like aspirin to work, we need to be seeing these women less than 16 weeks. It has been shown that it is that time or before that time when we are probably going to derive most of the benefits. But look at this graph. It is showing that 52.4% of our women came at a gestational age of more than 16 weeks. Only 29.8% actually came less than 16 weeks. Therefore, if we're to make any meaningful change, it was only going to be probably in this 29.8%, and that is not enough. In the middle here, we are saying, what were we doing? What was the indication for that cesarean section? You would see there that the commonest was preeclampsia, severe preeclampsia, followed by eclampsia. So we've got many of these women that are coming in with eclampsia. 23.3% of these women actually had eclampsia of the cohort that we actually looked at. Then we said, at what gestational age were we doing these cesarean sections? 44.7% of these patients were actually done at term. 55.3% were preterm. So we are delivering these women preterm or prematurely because of the underlying condition. Sorry, let me just then we said to ourselves, we said, what are the birth weight? We then went on to further deep dive into the data to say, what were the birth weights that we got from this cohort of women? You see there from the graph, 7.8% were less than 1,000 grams, 1,000 to 2,499, 51.7. So you'd see that the majority of these women actually were delivered prematurely, had low birth weight babies. We said, what about the APGAR scores? It's very terrible when you look at this graph, where 11% of those cesarean sections were stillborns, were IUDs. You would see FSBs, macerated births, 1 and 5, APGAR of 1 and 5, 18.4%, 6 and 7, 34%. Only 36.6% of these babies that we delivered had APGARs of 7 and or had APGARs above 7. So if you look at these statistics, they don't paint a very good picture and very good profile of our women. So I then went back and said, what has been proposed and what is it that the world feels we need to be moving towards. So in 2019, actually, FIC started an initiative on preeclampsia where they wanted to suggest a pragmatic guide for first trimester screening prevention. They were very unambiguous in what they said. They said all countries have an obligation to implement the best preeclampsia testing and management practice that they can, and that greater efforts are required to raise awareness of the benefits of early prenatal visits targeted at reproductive age women, particularly in low-resource countries. So you would see that we need to be doing something different from what is currently obtaining on the ground. Then I asked the question, so why should we be screening? We should be screening so that we're able to offer timely interventions as early as we can, because we know that early identification of women who are at high risk of developing preeclampsia is very important. And if these interventions are put in early, we're going to improve placentation and we're going to at least prevent or reduce the frequency of placental insufficiency. And even if we are not able to offer aspirin in those women who do not present enough, we are also able to ensure prenatal surveillance to be able to anticipate and recognize the onset of the clinical syndrome and manage it promptly. I'm going to come back to this point once again. So I'll pause here to put our second question to attendees to say, when should we screen preeclampsia? Is it at delivery? Is it before pregnancy? Or is it in the first trimester? Then I said for us to be able to understand the screening method that we are proposing or that has been proposed, we need to be able to understand a bit of the pathophysiology. I think we all know and we've come across the fact that although we do not completely understand the pathogenesis, and that it is, although it remains a bit unclear, but we know that there is a current theory that seems to suggest a two-stage process, where we know that there's shallow invasion of the trophoblastic tissue that results in inadequate remodeling of the spiral arteries. And this is thought to occur initially at 8 weeks, and that this is a subclinical phase. And it is this subclinical phase actually that then creates this window of opportunity for us to be able to predict and prevent preeclampsia. But once this subclinical phase has not been attended to, then there is presumed that there is now a second stage where then there's a maternal response to this endothelial dysfunction that then leads to some angiogenic and anti-angiogenic factors. That these are the ones that then give rise to the clinical syndrome. So if you look at the bottom here, that we have got immunological factors, pre-existing factors, genetic factors, and an increase in placental mass that then feeds into an abnormal placentation. And because of the reduction or because of abnormal remodeling of the trophoblastic cells in the placenta, you actually now get reduced placental perfusion. And it is these anti-angiogenic and angiogenic proteins that become very vital in ending up with a systemic vascular dysfunction. This slide is proposing more or less the same thing, that as long as we fail to have normal vessel remodeling, we are on a downhill slope in terms of developing hypoxia, in terms of increasing this protein, decreasing some of these angiogenic factors, and we end up with endothelial dysfunction of maternal vessels that leads to a maternal syndrome. So it is thought that really at the biochemical stage, we actually have an imbalance of these two important factors that I'm going to speak about in the slides that follow. And it is this imbalance sort of that leads us to the hypertension, to the proteinuria, to the cerebral edema, and to the liver dysfunction. So screening. So when should we be screening for preeclampsia? So preeclampsia, in my own opinion, should not be a once event or a once in all event where you spend the first trimester and you forget about the woman. But there is a proposal from the Fetal Medicine Foundation and the gurus in preeclampsia that screening at 11 to 13 weeks will be able to identify women who are at high risk of developing the condition, who can actually have aspirin or calcium, which can then substantially reduce the incidence of preterm preeclampsia. I know that in our setting, we're probably at the moment not going to be able to achieve this, but however, we still have an opportunity again, even in the second and third trimester, that though this screening may not lead to us giving aspirin or calcium, but however, it will lead us to be able to identify those women who are at high risk, where we can then offer them intensive monitoring that could lead to an early diagnosis of preeclampsia and, of course, a reduction in the adverse perinatal events associated with the disease. So all hope is not lost in our scenario where we cannot be able to find these women in the first trimester. We can still be able to do something even in the second or even in the third trimester. So I'm really not talking about something that began yesterday or something that began soon. So there has been quite a number of studies and a number of timeline and critical events dating back to the 2000s, where people actually started to recognize that preeclampsia was becoming a problem. But I want to highlight a few of these. In 2010, they came about the NICE guidelines. I'm going to discuss those in detail. That actually started screening for preeclampsia using maternal factors. In 2013, the ECHO guideline also came out. In 2016, that's where we've got the Fetal Medicine Foundation, first trimester prediction by computing this model. That model has actually been refined up to date. So to date now, we have got, in 2018, there was some latest ECHO guideline that actually came through. And in 2019, like I've already highlighted, FIGO actually endorsed the first trimester screening method as proposed by the Fetal Medicine Foundation using the triple test that I'll come to. I'm sure most of you are very familiar with the slide, where we've been using, even in Zimbabwe, we've been trying actually to use, or even without success, trying to use the binary scoring system, where we are categorizing women into high risk and moderate risk and looking at their risk factors to say who is likely to develop preeclampsia. These were proposed by the NICE, the ECHO came its own guidelines, and even Society of Fetal Medicine came up with these guidelines. But however, it has been shown that though simple, the detection rate for preeclampsia using only maternal factors, that is for early preterm preeclampsia, is only 40%. So if you are going to be using risk factors alone, you are going to be missing probably 60% of women. These are the women who come fitting in labor, who come with severe preeclampsia, and you are wondering, where did all this eclampsia develop? When did it develop? It developed because even if you're to use these, strictly speaking, you are still going to miss about 60% of these. And again, like Dr. Verenga said, it is pointless to categorize someone as low risk or high risk. How high is the risk? Do they have a personalized risk? Give them a personal risk, because just saying high risk or low risk, how high is that risk? How low is the risk? So we need to be moving away from this and adopting this early prediction preeclampsia model by the Fetal Medicine Foundation that says you need to be able to identify a priori risk for this woman using the maternal risk. You add to that risk the biophysical markers, you add to that the biochemical markers, and you come to what they call an adjusted risk. So it is no longer business as usual or no longer recommended to be using maternal risk factors only, because we've seen that detection rate misses about 60% of women who will eventually develop the disease. So how did this model come about? This model came about through use of multivariate logistic regression analysis, where it uses a combination of maternal factors, the mean arterial pressure, the uterine artery peak systolic velocity, the serum PAP-A in some places where placental growth factor is not measured or cannot be determined, and at 11 to 13 weeks of gestation. And we know that if you to apply this model, your detection rate rises to about 3% and 36% for the prediction of early and late onset preeclampsia respectively, if we're to have a false positive rate of 5%. So it is superior to the detection rate of the traditional checklist-based approach, which relies on maternal factors on. And this model is actually evolved over these past few years to be the best model available at the moment. So how does it perform? So if you are to look at the blue, let's concentrate on the blue for now, for preeclampsia less than 37, for preterm preeclampsia. So you see, if you're going to use maternal factors only, your detection rate is only 45%. If we're to add the mean arterial pressure, that detection rate goes to about 51%. If you're to do an ultrasound scan of the uterine artery pulsatility index, it goes to 58%. If you're to use, that means if you're using the maternal factor, and the scan, you 58%. If you're to combine the three, the maternal factors, the mean arterial pressure, and the uterine artery Doppler, your detection rate goes to 68%. And if now you use the biochemical markers, you add placental growth factor to your screening method, that goes to about 75%. So you can see that there is an increase of around 30% detection rate that you're going to achieve by using this model rather than using maternal factors only. So how good is this model? Is this a model that can be applied anywhere else in the world? Yes, there have been many other validation studies of the same model that have been carried out in Europe, that have been carried out in China. But sadly, you can see that Africa remains alone and solitary. So it has not been validated in our setting, but it does not necessarily mean that it cannot be applied. So you can see that this is a model that that has been done in most populations, and it has actually been shown that it is able to give comparable predictive performance corresponding to original studies in the original populations in which it was done. So it is not a model that can be doubted. It is a model that can actually even be used in our own setting. So this will be my third question to our attendees, to say the recommended dose of aspirin prophylaxis. Is it 75 grams A? Is it 150 milligrams B? Or is it 100 milligrams C? So I went back to the literature to say, what are the screening guidelines that exist currently? What should we be doing? How should we be doing it? So we know again that mean arterial pressure must be measured as part and parcel of any preeclampsia screening method, and that it is more useful than measurement of the systolic and diastolic pressure. I know that in our setting, we usually say 160 or 110 is severe preeclampsia, but we need then to determine what is the mean arterial pressure. It has been shown that it is actually more useful than just determining the systolic and diastolic. And we know that in pregnancies, that preterm preeclampsia, the mean arterial pressure is increased. Right. The other question that I want to ask, the last one, is if the cutoff is, if the cuff that we are using to measure the blood pressure is too large, will the mean arterial pressure be underestimated or overestimated? So this answer is a true or false. If the cuff is too large, are you likely to underestimate or to overestimate the mean arterial pressure? I also want to emphasize that this measurement of mean arterial pressure should not just be a haphazard means. It's not just done haphazardly. There are proposed recommendations on how this should be done. We know that the person must be sitting upright with their back straight. The arm cuff should be placed on the arm at the same level of the heart, that the hand must be relaxed, and that the patient must be sitting comfortably with their feet flat on the floor. We also know that we need to use an appropriately sized cuff. I'm not going to put much emphasis in this, but it is important that this measurement must be done after I rest for 5 minutes. I've seen some people who have just walked up a flight of stairs. They are measured the blood pressure. Some are talking. Some are engaged in other activity. So it is not the right way to be measuring the mean arterial pressure. Why am I putting so much emphasis in how the mean arterial pressure should be measured? Because we know that if there are errors in determining this blood pressure, we are likely to have some variations. For example, if the arm is unsupported, there is a variation of 10 millimeters in the blood pressure that you are going to get, in the mean arterial pressure that you are going to get. If you just wrap the cuff over clothes, which I've seen sometimes happening in some of our hospitals that I will not mention, you have a variation of about 5 to 50 millimeters of mercury. I know that it is winter, so people sometimes they don't want to cause hassles to the patient, but we need to apply the cuff on the skin and not over any kind of clothing. If the patient is talking, look at it, 10 millimeters of mercury variation. If they have a full bladder, if they are sitting with cross, so it is these seemingly a very simple things that may actually make you miscategorize someone, make you at the end of the day have a very wrong risk for that particular individual that we are seeking to assist. We know also that we need to be determining the uterine artery systolic or mean uterine artery pulsatility index. So it should be measured, or it should be done in the context of screening for pre-eclampsia. And we know that it tends to be high in pregnancies that have impaired placentation and at high risk of developing pre-eclampsia, and that it can be performed either transabdominally or transvaginally following a similar technique. And if we're to use it alone, your detection rate of late onset preeclampsia will be 26%, and the detection rate for early onset preeclampsia is 48%. So it seems to perform quite better for early onset preeclampsia. So it must form part and parcel of your for your screening protocol, whatever protocol you're going to adopt. Some of my colleagues, I think, have spent quite a lot of time discussing how this should be obtained transvaginally, abdominally, and what are the issues to do with method of determining it that you are going to be using. So I'm not going to spend a lot of time on this, except to say that there is a protocol that one is to follow from ISWOC, from the Fetal Medicine Foundation side of fetal and maternal medicine. There are many protocols that you can, but all of them really seem to suggest almost the same thing on how you ought to determine it, on how you ought to set the sampling gate, on what angle of insonation you should use, on what your peak systolic velocity should be, and how you should, in fact, be able to determine the average pulsatility index. So I'm not going to spend a lot of time on this, except then to come to this, say, there are very useful biomarkers that have been shown to be very useful, that if we're to be added to your maternal factors, to your mean arterial pressure, to your scan findings, and then you add this, you are likely to get your detection rate to quite very high levels, and you're going to be missing very few people in your population. And one of those suggested is placental growth factor, which we know that is synthesized by the placenta. It is part of the vascular endothelial growth factor, a family of proteins, and it is a potent angiogenic function. So in pregnancies that developed preeclampsia, it tends to be lower than in normal pregnancies as a consequence of placental hypoxia. And if you look at the detection rates, they are quite reasonable, 55% for early onset preeclampsia, 33% for late onset preeclampsia. So I come to this because we are going to, it has a bearing on what you do in the second, also in the third trimester, the serum soluble FMS-like tyrosine kinase 1. So it is an anti-angiogenic factor, And it has been shown that in those patients with established preeclampsia, their levels tend to be increased. And we know, or studies have actually shown, that this increase in their levels actually precedes the development of the disease by about 5 weeks. And then after that, it then appears to correlate quite well with disease survey. So it is a very, very useful anti-angiogenic factor that we need to be able to think about for the future, even in our setting. But however, there's more caveats to it, that it is not routinely used for the first trimester screening, but is useful in the second and third trimester, because if you're to measure it between 11 and 13 weeks, it does not seem to improve the prediction of preeclampsia, even if you're to compare this with maternal factors alone. So it is most useful if you do it around 22 weeks for you to be able to predict preeclampsia in less than 32 weeks. And we know that if you measure it at 36 weeks, it will be very useful for you to predict preeclampsia at greater than 37 weeks. So you see that throughout pregnancy, there's no point or there's no stage of that pregnancy where you cannot have some form of prediction of whether this woman is going to develop preeclampsia or not. Why I'm saying this is because I've heard many people saying, our women, they present the second trimester, their disease has already started, there's nothing that we can do. There is something that we can do if we seriously think about what else we could offer at whatever gestation that they are going to be presenting it. So there is no time where you could say, there's nothing I can do about this patient's prediction of preeclampsia. You can see that you could actually even measure the serum soluble FMS like tyrosine kinase, even at 36 weeks, to see if a woman who developed preeclampsia at greater or equal to 37 weeks and offer surveillance and early diagnosis and be able to deliver that woman earlier than necessary. So having spoken about all this, how then do you personalize, how then do you assign a risk to a woman? I think Dr. Verenga, before the break, showed this screen. So what has happened now? Once you have done your maternal factors, so your maternal factors with the FMF and protocol you are going to come up with this, where you're going to, if you are to do, like Dr. Verenga spoke about how you can be licensed by the Fetal Medicine Foundation for you to be able to use their protocols. So you would come to a screen where you are going to put everything, the maternal factors about that patient. You are also going to be able to measure their blood pressures, the mean arterial pressure. You are also going to be able to do your scans and be able to put your uterine artery pulsatility index. After that, you're also going to be able to determine the placenta growth factor, the levels of PAP-A, and many other things that you may be able to determine, the other biomarkers. So at the end of the day, the screen, or what is going to show you, is going to be able to show you something like this. I mean, maybe Dr. Verenga quite clearly was able to demonstrate this, that once we have put in this, the calculator is able to give you the personalized risk of the woman. So in this woman, we see that her risk of developing preeclampsia before 34 weeks was 1 in 8,184. For fetal growth restriction, for spontaneous delivery before 34 weeks. So it is going to give you, at the end of the day, a personalized risk that we are then going to be able to counsel the woman upon and be able to offer the best care to that woman. So you should be able to put all this in the software that is going to then be able to calculate every day the risk for the woman. So the question is, so what happens when you've got that risk? How are you going to use it? So the next stage now would depend on that one is high risk or that woman is low risk. By high risk, we mean that the patient is a greater or equal to 1 in 100 chance of developing preeclampsia. And we know that it is only about 10% of our women who are going to be classified as high risk for preeclampsia before 37 weeks. And it has been shown, I'm going to come back again, that treatment with aspirin, 150 milligrams per day from 12 weeks to 36 weeks, will be able to reduce the risk of preterm preeclampsia by about 60%. So the other women who are going to score low, we are not going to tell them, go home, everything is okay, we'll see you at delivery. No, those women can be assured that development of preeclampsia less than 37 weeks is unlikely, but that they require reassessment of risk again at 22 weeks of gestation in the second trimester. Because this is important, because we have seen women who have been screened before, they're told their risk is low, but come back at 38 weeks fitting. It's because we have missed this very critical information to be able to supply to them. To say the risk is like a moving target, we need to be continuously engaging with this to be able to screen them in the second trimester and also in the third trimester. So we don't tell those women who are low risk to say, no, there's no chance of it developing preeclampsia. We even stop measuring their BPs. We even stop determining the mean arterial pressure. We need to continuously keep them with us so that we could be able to diagnose even a maternal condition early, be able to offer not aspirin in this time, of course, but to be able to offer antihypertensive treatment, admit them for steroids, and plan even an early delivery before we have intrauterine fetal demise. So this slide is trying to show us how we can go about screening in the second and the third trimester. So we don't stop only in the first trimester. This is the point I was explaining earlier, to say even if our women do not come in the first trimester, there's something else that we can still do for them in terms of their risk assessment, even in the second and the third trimester of screening. So you would see here that in the second trimester, if we are to, I can see my pointer, if now we are to add SFLT1 for those countries who are well resourced, there's 100% prediction now in the second trimester of preeclampsia developing before 34 weeks. So there's something that you could do by adding the other marker. You see even here that at 32 weeks, if you to add SFLT1, you have 98% prediction of preeclampsia before 37 weeks. So it is important that we continuously offer these women screening again in the second and the third trimester. So this I put this up so that I could give a summary of how we ought to be moving in the algorithm. So in the first trimester, all pregnant women need maternal factors, mean arterial pressure, we need to scan them, placenta growth factor. We risk evaluate for preterm preeclampsia using the software. We're going to have high risk women, low risk women. High risk, we give them aspirin. We bring them again in the second trimester, where again, if we are to start in the second trimester, this middle one is if we are to start in the second trimester, all pregnant women, we offer them the same things. We include SFLT1. We again risk evaluate for preeclampsia. If we are high risk now, we don't offer aspirin, it's too late for aspirin. What do? We offer them high level surveillance for preeclampsia symptoms and signs between 24 and 35 weeks. And we are going to reassess again at 35 to 37 weeks of pregnancy. Those patients who are low risk and not on aspirin, we bring them again in the second trimester, we determine their risk. If they are still low risk, we offer standard surveillance, we reassess again at 35 to 37 weeks. So it brings me to the point that the risk assessment for preeclampsia is an ongoing. You don't stop at the first trimester or stop at second trimester. You can still find some high risk women even in the second or even in the third trimester, as demonstrated here by this algorithm. So we cannot speak about prevention of or screening for preterm preeclampsia or pre-term eclampsia without talking about aspirin prevention. We have got a lot of evidence in the Aspirin trial that have shown that without a doubt that aspirin really works. It has been shown from that study, from the trial, that if you're to put women on aspirin, you reduce their risk by 82% of them having preterm preeclampsia. So it is not a drug that we can underestimate. It's something really that is a very good tool, a very huge arsenal in our weaponry against preeclampsia. It has been shown that it is able to reduce quite drastically the chances of these women developing preterm preeclampsia. Of course, without much benefit in reducing term preeclampsia. there is this meta-analysis that I put here by Robert et al. In 2017 that actually affirmatively concluded thus, that aspirin less than 100 milligrams per day starting at any gestation has no benefit. Aspirin started at more than 100 milligrams a day started after 16 weeks has no benefit. It also showed that aspirin of more than 100 grams a day started before 16 weeks has a major benefit. So the dose matters, the timing matters. I've seen women who are on 75 milligram, women who are on 100 milligram. All that has no benefit in reducing that woman's overall risk. I'm running out of time. I'll try to be as fast as I can. So is this something that is feasible? Yes, it is something that is feasible to be able to do, especially in those well-resourced countries. How so? Because recording maternal history and the measurement of blood pressure are universally carried out as part of routine pregnancy care. So it is something that can be easily implemented, even in our own setting. And also that the measurement of mineral pressure is also done routinely, but it requires adherence to a protocol. So if we are to implement this, we need to adhere to a protocol. And we know that it can be undertaken by healthcare assistants after minimal training. What about the measurement of UTAP, of the pulsatility index of the uterine artery? It requires specific training of sonographers and quality assurance of their results, I think, which is something that we are trying to encourage, that we've heard about in the morning and throughout this meeting, that we need to be very good in undertaking these scans and following a proper protocol. And the machines are part of routine of ultrasound scans. That the same machines that we use in scanning women almost on a daily basis can actually be hooked up to be able to carry this of course, with the right training. And in those countries where they're able to do this, they actually found out that those same machines that they use for the unemployed in the first trimester can actually be adopted or adapted to be able to measure the placental growth factors. So what is the challenge in our setting? I think the biggest challenge was summed up by FICO in 2019, where they said a key barrier to prevention of preeclampsia in low-resource countries is delayed access to first antenatal visit or contact with a skilled health personnel. And that is removing these barriers to antenatal care, such as acceptability, affordability, accessibility, and even quality issues, can go a long way in making this a reality. Some may ask and say, of course, the tests such as placental growth factor, the uterine artery scans are not readily available in primary healthcare settings like ours. So what is the practicality of measuring the blood pressure and calculating the mineral pressure? And what about the software availability? Are we going to be able to have a software like this in Morambinda, for example, in Binga, for example? Those are some of the things that we ought to start to think about. So then in our setting, how can we then find a right balance? Are we able to do the standard test as recommended by the Fetal Foundation? Can we modify the screening protocol to have a two-stage screening strategy? What if we just use the maternal factors and miniature pressure and get the detection around 56% I spoke about? Will that be enough? It may be better than what we are doing now. What if we treat those with maternal factors only and screen those who are at low risk? If someone comes, we find that they on maternal factors, they're high risk, we put them on aspirin, and then we screen only those that are at low risk. What if we don't screen anyone and we give aspirin to everyone? If this screening is such a hassle in our setting. So I then thought, let me just discuss what someone could do with a two-stage strategy. The two-stage strategy actually seems to suggest that we could actually get the total population. We do the first stage screening where we are going to use the maternal factors and the miniature pressure. We are going to have some women who are screening negative, and those will be screened negative, and then we may then follow them up. But those who are going to screen positive are those then that we are going to offer a second screening stage where we are going to scan them and be able to include the placental growth factor. where in this kind of screening strategy, we're only going to have a baseline test that combines the maternal factor with mean arterial pressure in such resource-constrained situations. Why? What if we treat based on maternal factor and screen the low-risk women? Again, this approach seems to be very problematic to me because it does not offer a risk to these women that you would get through a standardized algorithm. And remember, actually, that it is the level of that risk that you determine. That determines what you are going to do in the second trimester or in the third trimester as a way of follow-up. And if you're to do this kind of method, some women may receive unnecessary monitoring and anxiety between the 24 to the 32 weeks period. So it is a strategy that may look good and may look cost-effective, but it has some underlying problems with it. Some people have said, you cannot do this in Africa. Why don't you give everyone aspirin? We are already giving everyone folic, you're already giving folic acid, you are giving everyone ferrous sulfate, and in high-risk women, you are giving malaria prophylaxis. So why not? What is the fuss about all this screening that you want to do instead of just giving everyone prophylaxis? So they ask, why should you go through this laborious process of screening if the most effective intervention you have is aspirin or calcium for the high-risk group? But we know that if we are to screen and assign a risk, you are going to get much better compliance from patients who know that they are higher risk and they are going to be taking a drug because they have a risk assigned to them. It has been shown that if we are to give everyone aspirin, the compliance, especially in those who are at low risk, actually is less than what you would get. Again, you'd ask, questions are being asked, what would be the safety of aspirin in those large populations? It may be better to give to those who are at high risk to be able to have a justification for any unintended harms that come from the aspirin prophylaxis. The risk of hemorrhagic disease, is it justified in low-risk women? So the question is, should we be targeted or should we be preemptive? So these are, I'm going to the last two slides, Dr. Venga, sorry for the time. So what could be the solution? So recommended the following. It said, you could do universal screening where all pregnant women screen them between 11 and 13 plus 6 weeks using a combination of maternal factors and biomarkers. So this will be the standard fetal medicine foundation protocol. But however, where resources are limited, routine screening for preterm preeclampsia by maternal factors and mean arterial pressure should be completed in all pregnancies. So if anything, we should not be using the maternal factors only, but we must endeavor also to add mean arterial pressure to whatever screening protocol that we can be able to achieve in whatever population of women. And once we identify these women, ideally we should put them on aspirin prophylaxis, not 100, not 75 milligrams, but 150 milligrams a night from 11 to 6 weeks of gestation. So how could we make a difference in our setting? We need to prioritize to be able to provide education, consistent adherence to clinical guidelines, and improvement in our referral pathways. And of course, Dr. Verenga spoke about this, the workforce shortages, availability of essential drugs, and even the gaps that have been identified in governance and in financing. So as a conclusion, I want to say this, that the current strategy of using only the maternal factors is not effective. We should do away with it. It is missing 60 to 70% of women who ultimately developed preterm preeclampsia. There's a strong body of evidence supporting combined screening. That preeclampsia screening should be part of routine antenatal care in the first trimester. And that this screening should be a continuous process. And that a minimum of a combination of maternal history and the mean arterial pressure makes a difference even in low resource settings. I wanted to end with what Albert Einstein said. He said insanity is doing the same thing over and over again and expecting different results. Thank you very much, Dr. Verenga. Sorry for not keeping up to the time. I'm done.
Thank you so much, Dr. Dube. Great presentation. on a hot topic. This topic is such a topic that we should all feel for it. If you are managing pregnant women, you know the kind of damage, the suffering that we have seen women going through. I think it's about time that we begin to make real changes on the ground. We need all people who do scans, from radiographers, sonographers, obstetricians, midwives. We need you to learn how to do uterine artery Dopplers. That's the first